Hello everybody, please join me in welcoming Hind Sbihi, today's speaker, who will be talking about opportunities and challenges in assessing exposure to traffic-related air pollution for birth cohort studies. So Hind is a PhD student here at the UBC School of Population and Public Health, and she holds a bachelor's degree in engineering from École Polytechnique de Montréal. She then worked in France for 2 years before moving to Canada and settling in Vancouver with her family. She then joined the UBC School of Environmental Health and obtained an MSc in Occupation and Environmental Hygiene, where she started to explore the field of exposure assessment in relation to noise exposure. For her PhD work, her research is centered around method development for exposure assessment of traffic-related air pollution to assess respiratory risks for babies. So, ladies and gents, Hind Sbihi.
Thank you, Sheila, and hello to everyone. Thank you for coming to my presentation today, which is entitled, as Sheila said, Opportunities and Challenges in Assessing Exposure to Traffic-Related Air Pollution for Birth Cohort Studies. So I'm hoping to present these opportunities and challenges by telling you the stories of 2 studies that I've been conducting for my PhD research. The first one is Hopanes and Dust, or the story of a novel metric. And the second one is a study that is currently underway, where I'm looking at the ATOPY development at age 1 and traffic-related air pollution. So for the remaining of the study, I will be just using the acronym TRAP, because it's a mouthful to be saying traffic-related air pollution. And in this study, I am examining whether improved exposure metrics influence the relationship between ATOPY and TRAP. Since we're looking at exposure assessment, we're looking at how we can best estimate the exposure of children with regard to respiratory disease, and in particular asthma and allergy. So a little bit of a background on what asthma is. Asthma really is an umbrella term under which there are different trajectories and phenotypes. It is believed that the underlying pathological basis for asthma is involves a series of inflammatory processes that, when repeated, they create characteristic smooth muscle contraction and mucus secretion and other changes. When these changes are unresolved, they lead to airway remodeling. And so airway remodeling is really the characteristic of what asthma is. Allergic asthma is the most prevalent form of asthma in children. And individuals with allergies, that includes also allergic asthma, which are conditions mediated by IgE, are referred to as atopic. The burden of asthma is quite heavy. In Canada, the direct costs of asthma is about $600 million a year. Taking a look at 1994, the cost of hospitalization alone for asthma in Canada was $135 million. Taking a step back and looking at it worldwide, the economic costs associated with asthma are estimated to exceed both tuberculosis and HIV/AIDS combined. There are also hidden costs. Mainly because asthma is the leading cause of school absenteeism, and so that leads to a negative impact on school functioning, and you can see how that can trickle down for adulthood consequences. So the trends in Canada for childhood asthma, we can see that there is quite a rapid increase over the past 10 years for children between the age of 4 and 11, and asthma is the leading cause of hospitalization for children between 0 and 4 years. There are multiple risk factors that are known, such as gender, family history, early respiratory infections, exposure to allergens, both indoor and outdoor, and finally tobacco smoke. So this rapid increase over such a short period of time cannot be explained by genetics alone, which leads the scientific community to think about environmental factors. One environmental agent to which everybody's exposed research from this group that Elaine Fuertes has presented about a couple of weeks ago the group for the International Study of Asthma and Allergy in Childhood, the ISAC study, to look at whether air pollution was associated with asthma. And they found for more than 500,000 children that were surveyed in 105 cities, which spanned 51 countries, that there was no association with moderate city-level residential PM10. Well, maybe there is something more to air pollution. And if this group looked in the later phase, in phase 3, at the portion of traffic in air pollution, so traffic emissions, by asking this question, well, how often do trucks pass through the street where you live on weekdays? And there were 5 possible answers: never, seldom, frequency, through the day, or almost all the day. Frequency through the day or almost the whole day. And we can see here that for both asthma and allergic disease, that there was a significant risk for those who were classified as high, those who had a high exposure to trucks on the streets, on the nearby streets, compared to those who were not exposed. And this risk was consistent for asthma, wheeze, asthma symptoms, eczema, and rhinoconjunctivitis. So what is TRAP? Traffic-related air pollution is made up of primary and secondary pollutants. It is a health hazardous mix of particulate matter, volatile organic content, polycyclic aromatic hydrocarbons, and gases such as the nitrogen oxides and carbon monoxide. To measure PM, because it is such a mix, we often rely on data that is routinely collected by the government. So in Canada, we have something known as NAPS, which are the National Air Pollution Stations, that have daily measures, actually hourly measures of NO2 levels, PM levels, and NO, as well as NO. So because they're so readily available, they are commonly used in observational studies to reduce financial and logistic constraints. Recently, the Health Effect Institute has published a report where they looked at TRAP health outcomes and ascertained the biological plausibility. So basically, what is the mechanism that explains how TRAP affects different health outcomes? So it is associated with reproductive, cardiovascular, and respiratory health. My focus here is respiratory. And biological mechanism for asthma and allergy really follows 2 pathways. The first one is the immune pathway, where we have a skewed response leading to a greater Th2 activation, which increases the IgE production. And this is a pathway that is the most plausible for allergic conditions, including allergic asthma. The second pathway is the oxidative stress pathway, in which reactive oxygen species overwhelm our body, overwhelm our own antioxidant defense, and that leads to increased inflammation. So this report, looking at all the literature that has been published between TRAP and asthma and allergy outcomes, concluded that, and I have here showed you an excerpt from the report, that TRAP is an independent risk factor for the onset of childhood asthma. It's important to make the difference between onset and exacerbation. I think there's enough evidence that TRAP is related, that it is pretty established that TRAP is related to exacerbation, but the question mark is whether it is related to new cases of asthma. And what they said is that the evidence is in a gray zone between sufficient and suggestive. So what they've used to come up with this decision-making, they've used the US General Surgeon criteria that were used when back 40 years ago when for assessing the health effects of tobacco smoke. For allergies, the evidence was deemed inadequate and insufficient. So the important point is that the Health Effects Institute highlighted challenges related to the case definition that was pretty heterogeneous around studies, and as well as exposure assessment, because most of the studies that they reviewed relied on proximity measures. And some of them used the land use regression models, but these ones had issues too. There has been quite a strong effort after the publication of this report, and there are several recent studies, and I've highlighted here 2 local ones, one from Nina Clark, looking at allergy and looking at asthma and in the first years of life, as well as a study by Carlson looking at a high-risk birth cohort, where all of these studies have shown pretty consistent results relating traffic-related air pollution to asthma development in children. However, in all this evidence, the exposure was assessed at one time point, generally at the birth address of the cohort participants, when cohorts, people are followed over time. So how do we measure traffic-related air pollution? There are different models. In this table, I have classified them in order of how can I say, precision. Proximity would be the most straightforward approach, where we measure by how far a subject is from traffic emissions or traffic sources. And then at the end, we have land use regression and dispersion, which are the 2 most finest models for estimating exposure. So all these models rely on some form of measurements, and land use regression and dispersion modeling provide us with personal estimates of exposure at the address of study participants. But those are estimates of outdoor exposure, so it's basically what it is that you're exposed to at the address of interest. So the challenges in trap exposure assessment, really in sum, are these 4 points. First, traffic pollutants vary spatially as well as temporally. There is not one single metric for traffic. So traffic, because it's a mix, NO2 captures some of it. Some people have used PM 2.5. And there are other non-traffic sources that contribute some of the same pollutants to the ambient and indoor air mix. So let's take, for example, NO2. If I use a land use regression model that predicts your exposure at your home address, and you, at home you use a gas stove, then I might be not capturing what your gas stove is emitting, and this estimates that I'm giving is missing some of your exposure. And lastly, people spend their time in various places. You live at home, but you also go to work. You're you're commuting, and land use regression models, which are the type of model I'm going to be focusing on here, are models that predict your exposure at a given address, and usually the home address. So, thinking about indoor, we know that settled house dust is the most common measure to assess exposure to biological agent. Actually, the literature looking at indoor exposure to endotoxins and indoor allergens have used house dust as a single matrix. And it is an interesting matrix because taking one sample of dust, you have the possibility to look at different chemicals, different agents, including chemical agents such as PAHs and Hopane. So Hopanes are organic tracers of traffic-related air pollution. They've been used in source apportionment studies. They're found in engine oil lubricants, and they're not a product of combustion. Because Hopanes are made of long chains of carbon between 27 up to, I think, 35, they are relatively stable and non-volatile. So they would actually settle on the dust and presumably attached to the dust particles. So Hopanes in settled dust may then provide a measure of trap, accounting for the between-home variability in infiltration. The concept of the between-home variability infiltration is really important because it has been shown that even when you use a land use regression model to estimate your exposure, you can have two neighboring homes, and if one of the two is leaky compared to the sealed one, you are the people are actually exposed to completely different levels of trap inside their homes. So the goal of my first study was to examine settled house dust levels of Hopanes as a novel tool for assessing trap exposure. And these are this is the study population that I've looked at. I was able to have access to 3 different cohorts. The Windsor Ontario Exposure Assessment Study, conducted in 2005 and 6 by University of Windsor and Health Canada. T-Check, which is the Toronto Children Health Evaluation Questionnaire, conducted in 2006 and 7 at University of Toronto by Dr. Sharon Dell. And right now the undergoing Canadian Healthy Infant Longitudinal Development Study, or CHILD for short, which is a population-based birth cohort study covering 4 cities in Canada: Vancouver, Toronto, Edmonton, and Winnipeg. So by pooling all these cohorts, I was able to, and all of them provided dust samples as well as questionnaires. I was able to examine my the research question, which is to look at whether Hopanes were a tracer of infiltrated trap. So this equation translates what my research question is. We're looking at whether the concentration of Hopanes is related to variables that were traditionally used in land use regression models, and try to account for possible sources of Hopanes, if there were, and behavioral factors affecting dust deposition. So basically, if you have someone who is very obsessed by cleaning and cleans every time, he's not going to have the same amount of dust as someone who is a little bit more relaxed about the cleaning. So all these cities that I've mentioned have city-specific land use regression models have been developed. And so because land use regression models are regression models that combine air measurements from sampling campaigns and GIS information on traffic density or traffic density and traffic exposure to, as well as land use information, then my hypothesis was those geographic variables should correlate to Hopanes if Hopanes were in fact a tracer of trap. So for the dust collection, in terms of methods, the Hopanes were sampled for the child study in 2 rooms, in the child's bedroom as well as the family room. In Windsor and Toronto, the samples were collected from the living room only. So my analysis really was concerned with the dust samples in the living room. Dust was sieved to a size less than 150 microns, and that was to remove all the coarse particles before the analysis, before extraction and analysis through gas chromatography mass spectrometry for 11 monomers. All these samples have been analyzed at the same Environment Canada laboratory. The concentration of the 11 different monomers were summed for analysis. Now, I was fortunate enough that Environment Canada at the same time had made an effort to look at other air pollutant chemicals than those that are routinely collected. And in fact, at the NAPS monitor in Windsor, Edmonton, Toronto, and Vancouver, we had measurements of Hopanes as well as PAHs, but here we were using the Hopanes one. And so these ambient air samples were then compared to those that I had in the house dust by looking at whether it had the same fingerprint. By fingerprint, I mean the relative abundance of the major monomer over the total sum of monomers. And this comparison was matched by city and season. So for the results, I'll just go quickly over the questionnaire data, the trap variables that were looked at, the Hopanes level that we found, and I'll present the pooled analysis where we looked at all the 5 city togethers as well as city-specific analysis. And I'll also cover the Hopanes fingerprint comparison. So this table here shows the different levels of Hopanes that were found in the cities, and Vancouver had the highest level. This value here was really due to one outlier home that had close to 30 times higher level than the median of that city, the median concentration in Toronto. I also looked at the correlation between the Hopanes in the sample in each city with the NO2 that was estimated through the land use regression model for each one of Winnipeg, Edmonton, Vancouver, and Toronto. And what we found was that there was moderately significant association for Edmonton as well as Windsor. Now, looking at the fingerprint comparison, we found that that there was a significant association between the ambient and the house dust relative abundance. This association was stronger when we accounted for season and explained about 18% of the variability. I've put this busy slide here just as a way to explain a little bit of the challenges that I had when looking at all this, looking at all the geographic information. In fact, each city had its own land use regression model, and it came from different spatial databases. And in order to do the pooled analysis, what I did was to recreate these GIS variables so that I would have uniform or harmonized variables to do the pooled analysis. And basically, the main message here is that there's a large within city variability in land use, as well as population density and relative elevation. Interestingly, homes in Vancouver and Toronto are significantly closer to major roads than the other cities. The questionnaire data, again, same challenge. We have 3 different cohorts, so what we had to do was to look at each questionnaire and try to recode the variables so that we could have the same modifiers to account for. And what we found was type of floor, cleaning frequency, and type of house was not very different between the cities that we looked at. However, presence of a garage and season were significantly different for the Hopanes association. So the garage is an important factor because that's where you park your car. This is where you could actually track in some of your Hopanes inside the house. I just wanted to show an example of things that were specific to the city. For example, in Windsor and in T-Check, we have infiltration information, whereas for all the child cities, we have different sources of possible Hopanes emitters, like a gas station, for instance. So, for the pooled analysis, I ran a multiple linear regression, did not have a random effect because the intra-class correlation was close to 0, but we did put in the city as a main effect. And we found that there was a large amount of unexplained variability. The adjusted R-square was 0.08 in the final model. And this final model had relative elevation heating degree days, which is surrogate for, which is basically taking 18 degrees as the cutoff point for hot versus colder seasons, and then distance to highway. However, the city-specific analysis shed more light on the association between Hopanes and the geographic variables of interest. What we found is that we were able to explain between 10 and 80% of the Hopanes concentration, and most of the variables were those related to house characteristics and lifestyle factor. So the take-home messages from this study is that Hopanes, well, first off, can be consistently detected in house dust. There was a relatively good agreement between the ambient air samples and the house dust. So that means that there's probably a common source, and our hypothesis has good plausibility in terms of Hopanes in dust being representative of infiltrated exposure to trap. Hopanes in house dust were related to geographic variables used in the trap regression models only when housing factors were taken into account, and these housing factors differed by city. So Hopanes may be a useful tracer of trap exposure, but that is only when home-specific factors are considered. Moving on. So the Hopanes showed some promise, but there needs to be a better understanding of the deposition mechanisms, looking at the temporal and spatial variability of Hopanes in dust. Now, going back to how can we refine exposure assessment to trap, well, there are two facets. There's the spatial level and the temporal level. At the spatial level, the land use regression provides high resolution estimation, but there remains the question of how do we account for infiltration. At the temporal level, how do we account for moving? So when you follow up children over time, and if the family moved, which often happens, take for example a family who's expecting a baby, they live in a small apartment and baby's coming, so they want to have a bigger space. So how do we account for moving from one address to the next when the estimates that have been usually used in the literature only look at the home address at the time of birth? And then how do we account for location other than locations other than the home? So if the child goes to daycare and spends over 20% of his time in there, that will have presumably have an effect on how we classified his exposure or how we estimated his exposure. So that leads to a study that now I am currently undertaking. And this study is using the data from child, looking at ATOPY at age 1 and traffic-related air pollution. So as I said before, the Canadian Healthy Infant Longitudinal Development Study is this birth cohort study looking, which enrolls about 3,000 mothers at the time where they become pregnant. And we follow up these unborn children until their birth and until their, so for child until they're at age 5. In my case, I follow them until they're 1, because at 1 year of age, these children are, they get a skin prick test together with their mom. And researchers are often in touch with the participants of the cohort through different home visits and questionnaire that are filled out. So for instance, there's the questionnaire during the pregnancy where we get all the mother information on her SES, her smoking status, her health, whether she's atopic or she has asthma. The home visits that are done at 3 months, 6 months, and 1 year provide information about the house characteristics. And those are important when we look at ATOPY because those are risk factors like mold, leaks. Use of air conditioning is an important one because it affects infiltration. Well, it is known to be related to infiltration. Those questionnaires also have information about the child's time activity patterns. and as well as lifestyle factors. So we know through the questionnaire whether or not there is environmental tobacco smoke. Each one of the cities of the study has a land use regression. So in Vancouver, there's the model that has been developed by Sarah Henderson, as well as the new model from 2009 and 10 by Wong. Winnipeg and Edmonton have their land use regression that's been developed in 2007 and 8 by Dr. Ryan Allen. And in Toronto, there has been three different sampling campaigns where we have land use regression models for the years 2002, 4, and 6. For the purpose of my study, I used only 2002 and 4, since 2006 had very peculiar meteorological conditions. And I did a little bit of sensitivity analysis to look at how these two were different and decided to take the average of the predictions of the model. So the epidemiologic evidence around TRAP and ATOPY is not conclusive. The results are a little bit all over the map. Some are showing some association and others not. Recall that the Health Effects Institute report said that the evidence was not sufficient and not suggestive of an association. But in my case, this represented an opportunity to improve exposure assessment and examine this association by looking at using this land use regression NO2 estimates and trying to use the data made available through the questionnaires and try to predict infiltration or account for mobility, as well as look at time windows of exposure of interest. So this diagram here shows how the data, how I've organized the data to enable answering these questions. So on this arrow here, we have the time where we enroll the participants and they're given the residential history questionnaire, where we know the different addresses in which the family has lived before the birth of the baby. At the time where the baby is born, we get the information about from the on the birth and demographics. At the 3 home visits, then we get the environmental assessment of the house, and then we can get all the risk factors from the demographics file, where we know the gender of the baby, as well as from the environmental assessment, where we get all these questionnaires about the housing characteristics. So taking both the residential and home environmental assessment, we get the exposure data, and we have a total of about 2,000 children for which we know something about their exposure at some point between the enrollment and the age of 1. And then we have the skin prick test data at age 1. For this one, there were only 956 samples available for analysis. And these data allows to answer 2 questions. One that was really, the first question is really looking at the trade-off between how much effort can be put to get the best signal when we look at the exposure assessment. Whereas the second question is traffic-related air pollution related to ATOPY, and when looks at the tries to answer whether there are any critical time windows of exposure. So quickly, through the Lure models, if the address changes, we can do a time-weighted average computed for every period where a person has lived in different residences, and we can get the lifetime exposure. From the housing characteristic, we can use this study that has been done in the United States, looking at risks of cardiovascular disease from traffic air pollutants, where Dr. Ryan Allen has developed a model that uses readily available information and So this model uses window usage, forced air, temperature, and double pane windows questions to predict infiltration. So, and we have the same information from the child questionnaire, so it is feasible to map out this model and predict infiltration in the child homes. So here, I think it's important to know that about half of the cohort changed address at least once during the whole study period. So from the time the baby is conceived to the time the baby is 1 and gets his skin prick test, there is 44% of the cohort that has changed address. And so here you can see how putting all this data together can actually, we can see that if someone has, for example, 3 home addresses, and we know the information about the participant at the date of birth, we can see that at his birth he lives in the first home. At the home visit, he is in the second home. And at the 6 months visit, he's in the third house. So combining all this data, we can parse out the information and account for the moving as well as for the moving, and as well as trying to predict infiltration for each one of these homes. So before thinking about accounting for moving from one address one address to the other, there's a first layer of refinement or improvement that can be done, and that is adjusting for the temporal seasonality of NO2. So NO2 has a temporal pattern in a year, and rather than taking that one estimate of NO2 that's been developed, for example, in Vancouver in 2003, and trying to apply it for a baby that is born in 2009, we temporarily adjusted for he temporarily adjusted by looking at bi-weekly monitoring measurements and parsed out the data so that we could actually have his exposure over time. And so this was done for every city and looking at the yearly average for in each city at the time where the model was developed. A little bit about the health outcome. The skin prick test had histamine as a positive control and glycerine as a negative control. The allergen that were tested, I classified them as inhalant allergens and food-related allergens. So in inhalant, we had Alternaria, cat, dog, derpy, derf, and cockroach. For the food-related ones, we had milk, peanut, egg white, and soybean. Since these babies were tested, the wheel was measured in terms of the width and the length of the inflammation, and it was taped and recorded. So I had this measurements for both the mom and the child, and I categorized as positive if any allergen. So if he responded to any of this list of allergen here, if he responded positive, then he was categorized as an atopic child. In terms of quality control, the readings were discarded for those who responded to a negative control, and those who did not respond to positive control were discarded as well unless they responded to any allergen. So the risk factors that are known and that we looked at are the SES, by looking at the mother education, the father's education, the income of the household. The maternal risk factors that I retrieved was the ATOPY status of the mother, the smoking status, and her asthma, if she had been diagnosed by a doctor. The home visits gave us the information about the presence of pets and bugs, and we also had the information about exposure to environmental tobacco smoke. Gender and presence of siblings have been shown to impact atopy, so I've looked at those as well. So In this slide, you can see that there is quite a large variability in atopic status between cities, and Toronto is the winner, both for inhalant and for food allergens. They have about a third of the population that is atopic. Winnipeg, on the other hand, has a very, very small proportion of children with atopic status. And overall, children in this cohort are much more prone to be sensitized to food allergen than inhalant allergens. So from all of the children for which I had the skin prick test data, about 700 were assigned exposures during the first year of life or during pregnancy. And there was no systematic difference in exposure between the 700 and those without atopy information. So in this diagram here, I'm showing the unadjusted exposure in blue, it is still blue, and the adjusted NO2 estimate for the first year of life. And we can see that there is a drop when we do the temporal adjustment for the exposure. So, as I said, the mean unadjusted NO2 for the first year of life was 14.1 ppb. This is not accounting for change of address, but doing the temporal adjustment, we found that the mean exposure was 10.2 ppb throughout the 4 cities. How am I doing with time? Okay. So in this graph here, we see that we look at the difference between unadjusted and temporally adjusted NO2 estimates for each one of the cities. And basically what we can see is that during pregnancy, comparing pregnancy to the first year, there's a little bit of a change in exposure for each one of the cities, where the exposure during pregnancy was lower than the exposure during the first year, but it's not a significant change. However, the change really happens is quite obvious when we look at the unadjusted versus temporally adjusted estimate. For the looking at the risk factors, from this whole list of numbers, I think what I would like to highlight is that the risks were mostly significant for the inhalant allergens, where we see that the mother's status with respect to asthma, the presence of other siblings, her smoking status were significantly associated with the atopic status of the baby. And what we also found, which is a little comforting, was that what we know from the literature was indeed confirmed here in the results. So having a mom who smokes during her pregnancy multiplies by 4 times your risk of being atopic at age 1. And being in the higher category for SES is protective of a baby developing atopy. Those are the fresh from the oven results of this week for the analysis looking at atopy and trap exposure. What we have found is that there's a little bit of a difference between adjusted and unadjusted measures. And this analysis was adjusted for a city, the mother, asthma, smoking, and education. So those were the risk factors that were the most significant looking at from the univariate analysis. These numbers that I'm showing here are for one interquartile range, which means jumping from the lowest 25th percent to the upper, the 75th percentile of exposure. So what's next? in the upcoming month, I will be trying to account for change of address with this temporally adjusted metric. And then I will look at the effect of infiltration on the association between TRAP and ATOPY. And finally, I have about 70% of the participants who provide daycare information. So we do know whether the child is going to a daycare, and we do know the address of this daycare, so we can predict the concentration levels at the daycare. So quickly, a look on how the model for the study in the US is mapping to the child study. We have similar information for both the cold, so this is a model for both cold and warm season. And so for the cold season, we can map most of our, most of the predictors, except for whether the home has double pane windows. And that is not really a concern because the partial R-square for this variable is really low. So I'd like to acknowledge the people behind the scenes who've made the studies possible. From the University of Windsor, the Jiao Wong Ju's group, who collected the Windsor samples, Greg Evans' group at U of T, who stored the TCheck samples, Jimei Zhang and Louis Ding at Environment Canada, who did the GC mass spec analysis. Diana Lefebvre and Justina Green have been crucial in extracting the database after my several requests. And all the child researchers, as well as the Windsor and the TCheck teams, my supervisor, Dr. Michael Brower, and all the participating families. Thank you.
Questions from the audience?
Great talk, Hind. Sorry, this isn't really in the scope of your research, but I was surprised to see such a huge difference between child atopy between different cities. Do you know why? You know, Toronto would be at 30% and Winnipeg was at 1%. I mean, that's pretty significant.
Okay, I can hazard a guess. I don't know the exact reason, but I think you may be familiar with the hygiene hypothesis, right? So maybe there's something going on there. The Toronto children are different from children in Winnipeg. Just hazarding a guess, and children in Winnipeg would be out and about in farms or out in, and so they would be more protected following this hygiene hypothesis. So that might be a reason why. Yeah.
Any other questions?
I'm just wondering, in terms of using the dust methodology, if I was going to try to use this for a study, what variables do you think I should collect? And I appreciate I'm in Vancouver right now, so you've got your model, but if I'm not here, if somebody calls you, you're a PhD student, you get a call saying, I hear you're working on this, I want to try and use this methodology, what variables should I be collecting?
Okay. Well, that's an excellent question. And I think what I would, if there was, one thing that came out from the city specific, so there's two issues. It's hard to generalize because as I've shown, the variables that mattered were dependent on which city you lived in. So in Vancouver, the removal of your shoes when you come inside your house mattered. Whereas in Toronto, whether you cleaned your floor regularly mattered. So if you would give me this call, I would explain that I cannot generalize my results, but if you really were keen on using the dust, I would probably give you each one of those house-specific factors that came out and that were the most important ones to consider. Yeah.
Sorry, any other? Did you look at filter systems in homes, for example, HEPA filters in certain of the residences that might or might not make a difference in your hoping?
Yeah. So we did not have the information about presence or not of filters. So I think the closest way to look at whether or not your house is cleaner would be was to look at the cleaning frequency variable. So that would, I guess, if you are in the category of people who clean a lot, it has a double effect. Maybe you have less dust, but you also activate the dust resuspension in the air. But the exact question of presence of a filter, a HEPA filter in the house was not available.
All right, if that's all, please join me in thanking Hind for her great presentation on assessing exposure to traffic-related air pollution. Thanks.